Hello, I'm David Levine. I'm co-chairman of Science Writers in New York. I'm here with Dr. Stephen Morse, who I hope will unmute himself in a second. Okay, hi Stephen. And I want to thank Joseph Bonner for putting this together and also for recruiting Dr. Morse.
Thank you.
So from 2009 to 2014, Dr. Morse served as Global Director of PREDICT, a project of the United States Agency for International Development to strengthen global capacity for surveillance and detection of new infectious disease threats. His research interests focus on epidemiology and risk assessment of infectious diseases, particularly emerging infections, including influenza, and improving disease early warning systems. Before joining Columbia, he was assistant professor of virology at the Rockefeller University in New York. His book, Emerging Viruses, published by Oxford University Press, was selected by American scientists for a list of 100 top science books of the 20th century. He was chair and principal organizer of the 1989 NIH, National Institute of Health Conference on Emerging Viruses, for which he originated the term and concept of emerging viruses infections. Well, you got a big resume here, but okay, you're a founding chair of ProMed, because we're going to talk about that.
Okay.
The nonprofit international program to monitor emerging diseases, and was an originator of ProMed Mail, an international network inaugurated by ProMed in 1994 for outbreak reporting and disease monitoring using the internet. He was appointed to the National Science Advisory Board for Biosecurity in 2014. So thanks for joining us, and
delighted to be here, and thank you for that very gracious introduction. Certainly, I must say I don't recognize myself. No, seriously, but it's quite. Okay. Thank you very much.
Okay, so I was watching today. In 2019, you were at Columbia University talking about coming pandemics. Mm. So did you see this? Did you see a pandemic coming?
Well, when this started, this one, yes. Before, no. I don't think, we've never really stopped a pandemic. Certainly this shows it, or even recognized a pandemic until it entered the human population. Since many of these are zoonotic, from other species, programs like PREDICT have been trying to find out what's out there that might have the capability, like these coronaviruses, to jump into the human population. But they're usually surprises until they get here. I think by the end of December, early January, when the news first came out, it was clear that this was something spreading very quickly and rather intensely in Wuhan. And that, I think, was the first red flag I became aware of, that there was a pandemic coming. But as you know, pandemics like earthquakes do happen. They may not always be predictable, but they do seem to be inevitable given the situation of that we all live in, the situation of modern life.
So I was surprised to learn that this is not my first pandemic. There was one in 1968 and also one in 1957, but I don't really recall them. I mean, I was in, I don't know where I was, in college, but Woodstock happened in 1969. The Mets were playing to sold-out games. They won the World Series in 1969. So what was the difference so that was the Hong Kong flu. Yeah. So what's the difference between that pandemic and why we're all wearing masks and watching empty stadiums?
I think that's an excellent question. One of the answers is that, we've sort of gotten used to flu pandemics. They're not trivial. The worst natural disaster, as we know, in all of recorded history was probably the 1918 flu, and there's still a lot to be explained there. And we were wearing masks then too, so people were taking basically the same precautions that were available then. But we've had several flu pandemics, as you mentioned, 57, 68, 2009, which may have, because it was relatively mild as these pandemics go, may have lulled us a little bit into a false sense of complacency about it. And we've really never stopped any of these pandemics. It's theoretically possible, but we usually just sort of live with them until they're over or until we get a vaccine, enough people can get immunized. This is different in part because this is a coronavirus. And the pandemics we've dealt with in the past, not counting HIV, which I think also legitimately counts as a pandemic, or some of the earlier ones like cholera and plague and so on, the viral pandemics at least, that, you know, respiratory viruses especially, flu pandemics, all of those have been caused by influenza viruses. And they're not really very predictable. They're very hard to see coming until they start getting here. But we've never had a pandemic like this in our lifetimes with the coronavirus. That's a different virus family. We obviously have had bad experiences with the original SARS and with Middle East respiratory syndrome, both coronaviruses. And so I think there was a lot of concern that we didn't know what was going to happen here. We don't know with flu pandemics, but we've gotten used to that. In this case, it's a completely different virus family. And, you know, it's had some bad history, although there are some human coronaviruses that are so familiar to us, we don't even know that they're circulating. They've been here a long time. But the coronaviruses we've seen in this century, like SARS, you know, have been very bad actors. And so naturally, we would be concerned about this. And the other thing is that the degree of severity, the lethality or virulence, the seriousness of this infection is not 1918, thank goodness, because that's unique, but it's also more, as even the president said, you know, even more than our strenuous flus, meaning that it's probably a little bit, maybe more than a little bit above 1957 in severity. And we still don't know what it's going to do yet. So I think, you know, all those unknowns mean that it bears careful watching. And this is really the first time we've taken it this seriously, although you could argue whether we really have taken it seriously enough.
Well, it also seems to be increasing in a lot of countries in the world, like France and England and I think Japan. So it's not, I mean, it's increasing in 35 states in the United States, but not just here. What is causing the increases?
I think a number of different things, but I think, you know, in a number of places, it simply, when it originally was introduced, it wasn't really effectively controlled. So in Italy, in Spain, sadly, in a lot of Western Europe, in a number of countries in South America, with the exception of Uruguay, just like the United States, there was really very little initial control. And so it got out of hand, just as it had happened originally in Wuhan, China, where it expanded. This does transmit very well, at least as well as the flu. Basically, we get infected by the same roots. And, you know, the respiratory, maybe the eye. And it is quite transmissible from person to person. We've known that for a while. But some countries have successfully controlled it. And they've done it by, you know, trying to start earlier, or at least find, you know, the traditional test and trace, which is a Herculean job, but it's going to be almost an impossible task with the numbers we have now. Now, some other countries that thought they had it under control probably still had some individuals who were infected, but you can get a lot of asymptomatic infections that, you know, are not very obvious, but they can still pass it on to others. People who we call pre-symptomatic, who look asymptomatic until they get sick. So they can pass it on too. So the people who really are the sick ones, the ones who may eventually get hospitalized or seek medical care, are probably, we don't know the exact numbers. From the evidence we have, they're not the majority of the people who have the infection. So there are a lot of people who can pass it on unawares, and then it will spread, just as the flu does, essentially. One person passes it on to 2 or 3 others on the average. That seems to be about what it does. And then, it snowballs very, very quickly. In a few countries, it was reintroduced by someone coming in from another country and who was infected and could infect others. Probably in Europe, it was smoldering along as it has in the US in some places, and then just suddenly the right opportunity came, enough people got infected, suddenly you see a peak.
So I just want to tell people who are listening, and I thank you for listening. There's a Q&A box on the bottom. If you have questions, please put them in there. Don't put them in the chat box, please. Put them in the Q&A box. And so far we have none. So so please ask your questions and we'll get to them. So I was listening to CNN today, and Nicole Wallace was saying that what surprises her is that the countries that are doing well, not the countries you would think are doing, not Western countries, but Korea, she mentioned, Laos, she just said is doing very well.
Vietnam.
Southeast Asia countries, Vietnam, which you don't think is the most sophisticated health countries. So what do they do differently that we should have done?
I think in most cases, in some cases there was a matter of luck, of course, but largely what it was they acted early and they took it seriously. So in South Korea, they had good reason to be concerned because they had an outbreak of MERS, Middle East Respiratory Syndrome, a different coronavirus, but in many ways there are a lot of similarities still going on in the Middle East. And they had an outbreak in Korea in 2015 where one person came back from, a Korean business person, came back from the Middle East infected, got sick, went into the hospital, and it spread through the healthcare system. It's not entirely clear exactly what happened, but that's how MERS generally spreads after the first few cases. And they had a number of cases, a really big outbreak in late spring and early summer, for those who think this is only a wintertime disease, in 2015. So with MERS, they had a real shock because it had gotten out of control, and they had to take some very stern measures, which I think was troublesome. So they were really quite concerned to make sure that this didn't happen again. And what they did was, when they found some individuals who were having symptoms and were sick, those are the easiest to spot, whether they have temperatures or they come for medical attention. They have fever, they come for medical attention. But then you have some way of testing them, and you have some screening tools, some kind of, not exactly like the diagnostics that they use for individual patients, but some kind of test that you can use, which is perhaps a little bit less definitive than your PCR diagnostics, but can help you to screen individuals, give you a pretty good probability, like the rapid tests, essentially. And they developed some. They did the same in Singapore. They made their own. They used them. Korea developed them very rapidly. And they tested people who were known to be sick, and then traced all of their contacts, all the people they had been in contact with. And it was particularly difficult because some of the individuals were just, people who'd become infected, usually in China, but there was a whole religious group, actually, that was in one city, and they did not believe in taking any precautions. They didn't think this was a bad thing. I don't know if any of this sounds familiar for those who follow the White House, former White House briefings. So they really spread it around quite a bit, and it was quite a job, both politically and scientifically, for the Korean government, the health authorities, to be able to find and identify all of these people who were congregating together. And this happened again not so long ago in Seoul. and they did the same thing. So it really requires concerted action as quickly as possible when there aren't very many, there aren't yet very many infected people, or enough, so many that you simply need a whole army to trace them. And you need a diagnostic, or screening to be more accurate, test to be able to do good surveillance. So one of these, just a little off the subject, but just free association. One of these recent events that was much in the news in Hong Kong was about a reinfection. Was really very definitive, because this person, a young man, had become sick, and they had tested him and he was positive, and then he recovered, and then he went and traveled somewhere where there was in fact an outbreak, I think in Europe, came back, and he was fine. But strangely enough, at the airports, they happen now to be using actual testing for the virus. And they identified him as being infected and shedding, producing virus, therefore able to infect others. He felt fine, but they also determined that he had a different virus variant that was circulating where he'd come from, not the one they compared it with the one he'd originally been infected with. So it was clear that he was reinfected. It was also clear that we wouldn't have picked it up if we hadn't tested. And there would have been more cases.
So I have a question from from a family member who has to leave in 10 minutes, so I want to ask it. Should we encourage herd immunity as promoted by President Trump?
I think it's a concept it's an appealing concept, but I think there is no practical way to do that. And the reason I say that is, first of all, they tried doing that, I think, on whether officially or not, in the UK initially, and realized that the consequences were very serious. Secondly, we don't really know what herd immunity means, in the sense that we don't know how well protected against reinfection or subsequent infection someone is after getting this infection and recovering from it. And this is going to be a problem with the vaccines as well, some of which have other problems. We don't know how durable that immunity is, in other words. So, that means we can't really depend on immunity, or the immunity passports people talked about in the past, to give us real protection. But the idea of herd immunity, I think, is at a very high price. There are great consequences, even if you try to protect the more vulnerable, such as the long-term care facilities, where in most places that have them and that had cases, in many states, 40 or 50% of the deaths have been associated with those facilities. So those are the first places you'd want to protect, but we haven't done a very good job protecting it. So I think the herd immunity idea is simply not feasible. And I don't think it's going to be a pleasant thing if it actually plays out that way, which is almost what's happening anyway.
So what have we learned from the past pandemics that we can apply to this one?
Yeah, I think that's a very good question, because after working on trying to prevent all the pandemics, I'm sort of reminded of something Ray Bradbury wrote some years ago. It's become my favorite current quote. People ask me to predict, I'm going to paraphrase, I probably won't get it quite right. People ask me to predict the future. That's what we epidemiologists are, supposed to try to pretend to do anyway, but when all I want to do is prevent it. And the reality is, we spent a long time with ProMed, for example. That was in the 90s, following the Emerging Viruses Conference, during a time when WHO was not active and actively taking this on. And the idea was to build a network to try to get better early warning of these infections. So, the question is, what do we learn from history? If we had learned from history, I hate to sound cynical, but we should have been able to prevent this pandemic from getting as far as it did. In fact, when I first saw it, I didn't think it would come to this, because I thought certainly we could take the right measures, as some other countries had done, to contain it. maybe not completely, we wouldn't completely eliminate it. We've never stopped any pandemic. But on the other hand, at the same time, I expected that we would be able, since we knew it was coming, we could build certain defenses, including those screening methods that would tell us before people came into the country. And they did a lot at the airports, but not enough of the right things. So we did a lot of the right things, but much too late. And I hope we will learn some things. One thing I hope we'll learn is how better to act, the need to act quickly, and how to give this a higher priority, because we obviously didn't take this very seriously in many countries. One thing I hope we learn, I was really shocked at the lack of global coordination. During the original SARS outbreak in 2003, WHO, the World Health Organization, actually, actively brought people together, brought scientists, epidemiologists, clinicians together in groups to share information. It may have been, obviously after it had already started to spread, but that was extremely useful in coordinating the various plans. And I haven't seen that here at all, even in Europe, where you have all these structures like the European Council and the European Union. They came into this very late, and the European CDC. And I find that really puzzling, that each country essentially acted as if it were completely on its own. And of course, the US did that too. But, I think what we really need is the understanding that we need a global plan, and it needs to be thought out. And we've done a lot of exercises, right, almost up to the day the pandemic started. So, it wasn't a question of lack of preparedness, it was lack of implementation and following through on what we had learned. So I hope we will learn from this one that it really can be a national security threat. And it's not just, another flu, or the flu can kill too. And I also hope we'll make progress with some of the technologies, like for rapid testing, home testing, I hope, but we're not nearly there yet. And some of the therapeutics, and of course, some of the vaccine technologies that are finally being tested out, new technologies. So, it may be, and to solve some of the problems with flu, we never really knew, for example, this question about droplets versus fine particle aerosols. And I see that more as a continuum. But that was a question that came up with flu for years, and it was never fully resolved. So there are a lot of questions that came up with the flu and were never resolved, and they're coming back to haunt us now. I hope maybe we can make progress on some of those.
So speaking about the flu, one of the questions when we invited people, we said, could there be a twindemic, a severe influenza season on top of the ongoing COVID-19 pandemic this winter? Now, I know it's not easy getting a flu shot. You have to make appointments. Yeah. I have one friend told me she can't get the senior vaccine anywhere. And the drugstore said they're out of it. They're reordering it. And this is not a usual thing. I used to work at the Lung Association, and we were, 50% of the population would get a flu shot. The rest didn't get them.
Yeah, and that's
I still have friends who say, I don't want to get one. So
yeah, we did too. I teach a graduate class in emerging infectious diseases, ironically enough, at the Mailman School of Public Health, at Columbia, where I work, and where, as you can see, I'm doing this remotely. And I do the class remotely, ironically. But a few years ago, when the H1N1 2009 pandemic was going around, it came later than the regular flu season, so they had to make a special immunization, and they thought young people were actually at greater risk, so they tried to get to the young people first. That fall, I asked my class of about 35 people, all of whom are public health people deeply interested in this question, how many of them had actually had the H1N1 2009 pandemic flu. Several people raised their hands. A number of them had flu, and some of them had very bad experiences with headaches and all kinds of things that lingered for quite a while. And then I asked the class, how many of you took the H1N1 immunization? Almost nobody did. And I asked how many of you are willing to? And I was surprised at how few did that, although they took their seasonal flu shot. So I think that we have a long way to go still to counteract what is often now called vaccine hesitancy, as Heidi Larson calls it, and the WHO has officially called it. And unfortunately, you know, in some cases, there are some people who feel very strongly about that, but sometimes it's just apathy. So if the flu vaccine is less available, does that mean that more people are clamoring to get it? I hope we'll see a higher uptake this year. I think that will be a good sign.
Can you talk about what got you interested in viruses in the first place? And then what put you into the notion of emerging viruses in the 1980s?
Yes, and then I'll come back to the twindemic because it's an interesting question too.
Okay.
Yeah, I actually, like all students, you know, was wondering what I was going to do when I grew up, and became interested in microbiology because many of the key discoveries sort of life were being made with bacteria, with microbes. And, you know, that was just during that period. In the 60s, I was in high school. I graduated from high school in 68 and then went to college. And so I became interested in biology, and I happen to like, for some reason, you know, I happen to like challenges. I find myself attracted to things that seem like mysteries, and viruses were so. When I went to graduate school, it was actually in the old bacteriology department at the University of Wisconsin-Madison during an interesting time in the 70s, but they actually did have virology and all the other things. It was just a historical tradition. They've since changed the name, and I think the building, have a new building at last. But I became interested in viruses largely because they seem to do so many different things to exploit, if you will, the mechanisms of life, of their hosts, in so many ways that seem to encompass just about every evolutionary experiment in ways you could express a genome, for example, or package a genome, and doing it with such economy. And at that time, we didn't have sequencing. I won't even talk about that, you know, so it was a much different field, much more of the classical hands-on virology that is making something of a comeback. But, you know, if we'd had viral genomes in those days, that would have been something. But it was just interesting that, you know, this was like something that could in some way get at the machinery of life and do it in such a subtle way, and obviously cause a lot of effects as well. So it had important effects, but just as an intellectual problem, I guess that was really what interested me. And the emerging viruses, well, I will have to give the blame or the credit. I'm not sure what, to Josh Lederberg. When I was at Rockefeller, I'd been trained as a virologist. I worked in the lab, and I thought I'd spend all my life working in the lab, as like most normal virologists who work in the lab. And I happened just to go to a holiday party. In fact, there's an annual holiday party at Rockefeller. And Josh Lederberg happened to be there. And since he was the president, he was the host of the party. And his wife, actually, Marguerite, as I was going out the door, about to put my coat on, stopped Josh and said, Josh, you know, you had a virology question, and Steve's a virologist. Why don't you ask him? So we started talking about this, and he had some questions about some interesting, rather obscure viruses, but they were very interesting. But then one thing led to another. Josh always asked these questions that seemed to be really innocent questions. And then, you'd go home and think about it and you'd realize that these were really very profound, like the proverbial unpeeling the layers of the onion, and it would really hit you. So I began thinking about it. And of course, I was able to reassure him about the specific question he had, which was the risk to certain people working with viruses in the lab and in the animal facilities. So that question was easy. But then he wrote back a note saying, well, I mentioned some other interesting things that we were seeing with viruses. This was shortly after HIV in the late 80s. So it was a few years after HIV, AIDS, and as it eventually came to be called. As you know, it went through many different renamings, some of them quite embarrassing to the people who coined them. But that I think reawakened our realization that viruses would still be with us and that infections would still be with us. That, it was not, despite the optimism, we could not just close the book on infectious diseases and declare victory forever, because HIV was so different from everything else. I think it sensitized us, to that possibility. And so I got to thinking about some of the other things. I was working on a virus that attacked T cells, but was unrelated to HIV, and wrote Josh a memo about that, as I said, and included that with the term emerging viruses without perhaps being very clear what I meant by that at the time. And Josh wrote back a note in Olympian fashion saying this is a problem that needed to be addressed at the highest levels. And of course, being a young and naive assistant professor, I didn't appreciate that he meant really at the highest levels. He meant, the presidential level. So I decided to take the problem on. And anyway, I'm glad I did, because I like challenges, and it was an interesting intellectual challenge. And then, we all thought microbiologists tended to think it had to do with rapid evolution, the evolution of new viruses. And there is an important role there, but that's not really the most important thing. Now it's become a commonplace, but in 1988 and 1989, we had that conference at sponsored by NIAID, Tony Fauci's agency, and NIH, of which NIAID is a part. I think, we were all speaking prose, but didn't realize that we've been speaking prose all our lives. So many of us, the microbiologists, tended to think in terms of the rapid evolution. We know flu is an example, and it turned out that much of it was really the transmission of viruses between species that could somehow establish themselves in humans. And we've seen this over and over again, including the coronavirus right now. And in some way, it's a bit of a letdown to think, it's not this mysterious Andromeda strain-like thing. On the other hand, it made it possible to develop a framework for thinking about it and for attacking what seemed to be an insoluble problem.
So let's go back to the twindemic.
Okay, so the twindemic is an obvious concern because we don't know until it gets here what the flu season is going to be like. And then we have excellent people, my colleague Jeff Shaman, for example, who have various models for forecasting in the flu season. Once it starts off and reaches a certain point, you can, kind of forecast it forward. And although it's not perfect, it gives you some idea of what to plan for. But until it gets here, you don't really know. So there's always the fear that this could be a difficult flu season, even just an ordinary flu season, superimposed with this epidemic, this pandemic of the coronavirus. And that obviously we can see from this spring and summer that the coronavirus alone, the cases, can overwhelm a hospital's, in fact, a city's or a state's medical capacity. And we had a lot of very hardworking people on the front lines who were stretched to the limit with very limited support, like not enough personal protective equipment in many cases. But they were working overtime, stretched to the limit. And the fear is that we'll now have the same thing, but superimposed on that, the influenza, which also may require the same level of attention in a somewhat different way, but may require ICU, ventilation, or oxygen. And you already have a very stretched workforce and a very stretched healthcare system. And we know that even in a very heavy seasonal flu year, let alone something like this, that's often enough to really overwhelm many of the healthcare, even the larger healthcare facilities. And having two of them at a time is obviously a frightening prospect. Now, there are things we can do about that. And one of them is that all the prevention measures we're taking now, the masks, the distancing, the hand hygiene, and all the other hygienic measures, those actually are the same ones we recommended during flu pandemics and during bad flu seasons before a vaccine became available. And then eventually the vaccine would come and help. It wasn't perfect, but it would reduce, the incidence of disease. So these are the same recommendations in our pandemic flu plan. So I think if we do them as assiduously as we should, if we do them carefully, we could prevent the pandemic from hitting us again if we're really careful, and also reduce flu and other respiratory viruses. But that's a very optimistic hope, because we've seen a lot of situations where obviously the viruses have managed to spread quite well. And it's basically conditioned on human behavior, something that, strangely enough, we scientists don't necessarily understand very well. And it's hard to model. So how to get people to do things that are really in their own best interest and in the community's best interest, including immunization for flu, including all these other non-pharmaceutical interventions, as we call them, is really important, because it will save lives and it will prevent a lot of cases. So it's possible that we could avoid the twindemic. It's also possible that maybe it won't be such a bad flu season. In the Southern Hemisphere, which usually, 6 months offset in its winter and summer seasons. So their winter, is already over. As we go into fall and winter, they're going the other way. And it seems to have been lighter than expected down there. And it may have been due to all the precautions people were taking because of the coronavirus. If that's true, then it gives me some hope that we might be able to do something if we take the right actions.
Okay, so here's a question. The PREDICT project has just finished. Can you tell us first what it aimed to do, what it accomplished, and how will this data prepare us for future outbreaks? Will it allow virologists and immunologists working on making vaccines or therapeutics in advance of outbreaks?
Yeah, those are all great questions. So I was the global co-director of PREDICT for the first 5 years as it was getting off the ground. And I was really excited about it because, as you know, public health surveillance and global public health surveillance, as in the case of ProMed, early warning is one of my real passions, and I think it's really important. It's obviously not enough. We've seen that. Because we had enough warnings, we need to act appropriately as well. PREDICT, after all these experts, if you will, many expert, very distinguished expert groups, Josh Lederberg co-chaired one for the now the National Academy of Medicine and the Institute of Medicine, always recommended surveillance. And USAID, especially after the avian flu, H5N1, realized that there was a serious threat there, and we didn't know what it was, but it, could very well come and cause great harm before we realized. And we're in the midst of that now. But so, knowing that most of these, as we had parsed out in the 80s and later in some of the early work I'd done, knowing that most of these are zoonotic, they come from other species in the environment, the goal of the PREDICT project was twofold. First of all, to be able to get a better sense, using molecular methods by and large, of what was out there in other species, particularly other mammalian and some avian species where the influenza viruses usually originate, especially wildlife. And some generic PCRs were developed by one of my colleagues, Simon Anthony, to be able to do that. So you didn't have to know exactly what you were looking for. You could find a whole family. That's how much the technology had grown in recent years. That was 2009, 2010 or thereabouts, so that you could actually develop these PCRs. And we had developed some when I was at Rockefeller as well. Develop these generic PCRs by which you could find members of a virus family through sequences that they basically all shared, and then find out by sequencing the part, the amplicon as they call it, that you PCR up, that you amplify. You could find that part and sequence it and see whether it was something known or something different. And as a result, by testing a lot of essentially previously unsurveyed wildlife in a number of places around the world, especially in African parts of Asia, the traditional places you expect many of these pandemics and other things have come from. A number of new viruses were identified related to known viruses, but new, different Ebola viruses, for example. The other goal of PREDICT was to be able to get low and middle income countries where the project was working to be able to implement this themselves. That's why we went not the most high-tech route, but one that anyone who could do PCR, or if you could equip a lab and train the people to do PCR, and some of them were already doing it for other reasons like avian flu or other things, then they could adapt this method and use it to find other things as well and have the capacity. So part of it was building capacity in developing countries, and then they would generate the knowledge themselves of their own potential health threats. One problem, of course, is that you find a lot of things. How do you know which ones to pay attention to?
Okay, so I have two questions about animal transmission. So I'll read them both.
Okay,
They're
thank you.
related. One is, are there practical ways to reduce the transmission of viruses from animals to humans? And the second one is, what animals are we most concerned about that could serve as COVID reservoirs, even if we got human-to-human transmission under control?
Yep. So those are two excellent questions, and the answer is there's a lot we still don't know, but I'll take a crack at it. I think we're all interested, and there are ways we can prevent this kind of transmission. You think about transmission in the live animal markets, which gave rise to the original SARS, and arguably, we're not quite sure, but arguably this one as well, and certainly H5N1 and other avian influenzas. And mixing those species, putting them close together, often allowed for new combinations, or for something that was in one species to see if it could cross over, get the chance to cross over into others. So one obvious thing would be, simply to have much better hygiene standards. Some people would argue eliminate the live animal markets. I think that may be asking, that's a bridge too far, I think, for politically and culturally and socially. Many people depend for their livelihoods on that. But you can make them a lot safer by separating the species, by handling them much more hygienically, and by having the people protecting themselves, washing their hands, perhaps wearing masks. They don't always follow those precautions. With wildlife, the so-called bushmeat and so on, which is probably how HIV entered the world, simply the hunters can be careful about when they butcher the meat. I hate to be so gross about it, they too can protect themselves, with gloves or washing their hands. And there are a number of other simple things. After all, how many lives were saved by just having good potable water and improving the water supply and treating sewage? That almost essentially wiped out cholera in many parts of the world, including here, but there are other places that aren't yet so fortunate. So there are fairly simple things we can do, but we're, obviously not doing them And part of it is making it attractive to people so that they'll want to do it, that they see some benefit. So part of that is education or incentives, and that's difficult, especially in low and middle income countries. And it's difficult when you have a lot of, sort of uh, basement trade, that's unofficial and isn't officially regulated, but you can do a lot of education. In terms of COVID reservoirs, that's a really interesting question, because as with influenza, we never know where they're going to go. All of the influenzas we caught in pandemics, the 1918, wherever it came from, went into the pig population and circulated there. The last H1N1 from 2009 went into the pig population and circulated there. And it may have originated there after pigs and some waterfowl, the natural reservoir of the greatest significance, had a chance to somehow share their viruses. With the coronaviruses, in terms of source, we know that the vast majority of coronaviruses that have been found so far, not all of them, but a lot of them, are in various species of bats. And SARS has a lot of relatives in other bat species, and in the same bat species that SARS was found in, you can find relatives, that many of which, already look like they're well adapted for human infection. And I think we should have expected that one of them might have been able to transmit from person to person. I think we just got a little bit too complacent about the fact that SARS was not that easily transmissible most of the time. MERS, in a slightly different branch of the family tree, likewise. But the question about where it might go, it could possibly go into other bat species, but we've also seen infections in mink and other, technically they're called mustelids, but basically weasel-like animals. And I'm not terribly surprised, although it's unfortunate, because the first influenza animal model we had was the ferret. And to this very day, it's one of our best animal models for influenza and for several other, some of the, not all of the human coronaviruses, but some of them. And now that we're seeing it go into mink and similar species, similar to what we might expect in the laboratory when you're infecting ferrets experimentally, it could very well find a home there, because we know in the original SARS there was a similar type of mammal that was also infected in that that market. So I think we don't know what other species it will get into, but it's already done that, and I think that particular group of mammals would be one to watch. Rodents, we would worry about, obviously, but we don't yet know.
So here's an article from Peter Brown, who said, I was your editor-in-chief. One of the first features I ran as editor-in-chief of the Sciences was your article, Stirring Up Trouble, in 1990. Your point there was that environmental disruption can divert animal viruses into people. It would seem that with the acceleration of climate change, environmental disruption will place us increasingly at risk to novel animal viruses. If so, can you give us a sense of what we know about the enhanced risks we face in the next blank number of years?
Well, first of all, thank you, Peter. You obviously, I'm grateful for your having run that piece and been interested in it. And it's good to, I guess I can't actually see the participants, but it's good to hear from you. And I hope you're doing well. I hope perhaps in the Q&A box you can keep up. I'd love to hear what you're up to now. But I think obviously, without being presumptuous, I think that showed great vision. It's now become a commonplace. I think climate change is clearly something we have to worry about. We are seeing the climate changing, and it's often been talked about in terms of vector-borne diseases, better conditions for the mosquitoes in places where some of the tropical or near tropical mosquitoes have not been able to survive up the mountains higher up, where there's malaria or other infections, and now it's a little warmer up there, so they can go to further out, higher altitudes, and maybe, spread further to other places. But I think there are also indirect effects. With influenza, we don't really understand very well about the seasonality of influenza, but certainly things like influenza and possibly some of the coronaviruses, many of the respiratory viruses, will be directly affected by changes in climate. In what way depends on exactly what the change is, but there'll be so many indirect effects as well. Would it encourage people, would people now be encouraged to be indoors more with air conditioning, which might increase spread even if there is air conditioning? Would this affect agriculture, which might also affect the conditions under which even influenza pandemics emerge? So even something as seemingly mundane as influenza could be affected in many ways, some of them unfortunately very dangerous ways, by climate change. And there are many others that have been spoken about. So I think that is a real concern. And of course, all the other environmental changes that you mentioned in your question. A lot of land use change has been responsible for precipitating the emergence of infectious diseases, and we're doing that more and more. So, and then there are a lot of other things that go with globalization and some of its benefits, but we can also see, we have to be watchful for some of the unintended consequences. This outbreak of SARS coronavirus 2, the pandemic of COVID, being one of them. So I think it's an excellent point. We do have to worry, about climate change. And I think one of the things I worry about is we don't know exactly what's going to happen. So, how do we adapt and predict and predict the changes when we don't? We were seeing it happen gradually, and like the proverbial frog, in the pot that's being that's on a flame, we're unaware of this going on. We're, I think, aware of it going on, but don't know where it's going to end if it ever does. So it makes it hard to really adapt. But thank you for that question, and thank you for coming tonight. It's good to see you again. I wish I could see you in person, but very, very glad to be reminded. Thank you.
So here's a question. How does science control for cultural factors about diet? Can one control for things like eating certain wild species? Can we change or control for such things? How do scientists deal with this?
That has been a longstanding problem in much of the world. This is the main source of protein in a protein-poor world. So that's difficult, whether we can somehow substitute plant protein, or right now, Pat Brown's Impossible Meat is a little bit over, a little bit beyond the means of people in sub-Saharan Africa. But whether we can do other things there, I think there is more that can be done. And to make this safer, for one thing, if we are going to be, if people are going to have to consume wildlife, they should take more precautions in how they handle this meat, because usually after it's cooked, if it's cooked well, it's much safer. They may not have the means to cook it well, but if they're able to do that and they're careful in the preparation, we can make it much safer. Ultimately, I would like, obviously, I think, as your question implies, to see a world in which we can have good nutrition for everyone and safe nutrition. But I think we're not there yet. The World Food Program has done commendable work for which they were recognized appropriately this year with the Nobel Peace Prize. But clearly the fact that they still need to provide food aid as well as more sustainable methods, indicates that we really need to find sustainable ways to do this agriculture. So that's not much of an answer, because I think it's a tough problem, but I agree it's a very important one.
So here's a question. How has politics influenced the data collection and reporting of epidemiologic data?
Oh, not at all. Well,
Okay.
no. I mean, the reality is that unfortunately, this does become political. Countries are sometimes embarrassed or worse to admit, as in the case of SARS in 2003, it was about 3 months before China reported they had 305 cases in South China before the one in Hong Kong and before ProMed actually announced it about a week or two before the Hong Kong event, which was a real super spreader event. So countries fear the recrimination or the economic effects. People didn't come because they were afraid. However, I think transparency is a big help there. We've always argued that if you can build trust, and it really all has to do with building trust, if you can build trust and people know you're telling them the truth, then they're more likely to be open to a rational discussion in which you can quell their fears with good information. Unfortunately, it does often become political. So there's no denying that in this country, the reporting of SARS coronavirus 2, even the reporting of COVID, which is the disease that we would recognize in people who are sick, not just those who are infected and not obviously sick, is clearly very, very inconsistent. There are no national standards. They're reported in different ways. And there have been claims that some states have tried to minimize the numbers and by people who used to work at some of these health departments. So I think that's really hard, and especially in the absence of really good community testing so that you have some idea of what the denominator is. So these are highly political. And this is probably the one time that health becomes really important, because ironically, one of my friends who used to work at the National Security Council, Ken Bernard, used to say, nobody really cares about health because, it's thought of as something people spend money on rather than being a producer. And yet, it's a major part of our economy and it's very important to us. But in, the agriculture ministry, the economics or finance ministry, the defense ministry or departments, all outrank, in a sense, the health departments or the Ministry of Health and Public Health. So I think, clearly there has to be more cooperation throughout government and more consistency in how these things are reported. So it suddenly becomes political as now, when there are obvious concerns in the economic sector and the political repercussions. But I think it should not be. It should be like reporting the weather. We should know this regularly. It should be provided regularly. And we all know that the best way to provide this information is to be truthful. And when the information changes, as I think John Maynard Keynes said to someone, when the facts change, I change my opinion accordingly. What do you do, sir? So I think, we are open to going by the facts and being very careful about speculation. We saw a similar politicization in a slightly different way, more at the operational level with Ebola in West Africa, because that was not a big election year, but it was, 2014 was a midterm election year. And so we saw a lot of, action being taken and seen to be taken simply because of political expediency. And I think that it really has to be recognize these are public health issues. There shouldn't be stigma. We have to build trust with the community. And as a world, really globally work together. And that's why I'm puzzled by the fact that WHO has not been brought more into the mix.
So I'm going to end with this question, which is really about you. So what specific activities, dining, travel, weddings, gyms, etc., are you doing now, and what will you not do for a long time? So we already discussed you haven't taken the subway yet, but you think you might.
I haven't taken a subway. Yeah. So I mean, so do as I say, not as I do. No. I think, as the evidence with the subways suggests that if you take all the precautions you can, and you're careful, you probably will, have a very high probability of being safe. And we have stories about buses in China when somebody was, and those are just buses and rather crowded, somebody had this infection, famous story, not data, but a famous anecdote, and was on this bus and coughing, and many of the people on the bus got infected. And then he had to change buses, and he bought a mask, and he was still sick, but almost nobody, maybe nobody at all, got infected. So we have these stories which suggest that we can do things to better protect ourselves. In terms of family gatherings and so on, that's we've had some very, very limited, family gatherings, mostly outdoors under the conditions that, we've been recommended to take. Air travel, I think, is obviously a little riskier. I know a number of people have done it and tested negative at both ends. So it can be done, but unless it's necessary, I would avoid it. And it's clear that being outdoors is safer than being indoors. Good ventilation, although we don't know how to quantify that, is better, or how to quantify the safety factor, is better than poor ventilation. So I will definitely stay. I don't normally go to bars anyway, but so many of the new outbreaks came from bars. In Korea, there was one, and in Jacksonville, Florida, not so long ago, several weeks ago, and other poorly ventilated, crowded places. So I'll avoid those for the moment. I'll wait for the indoor dining just to see whether people develop a set of common practices. But I think that's a matter of personal choice.
So
be careful.
You've done outdoor dining.
I have not
Okay.
not as often perhaps as I might have liked, but I have many things keeping me indoors. But yeah, it's after a while you do want to go outdoors, but with a mask, with all those other precautions, and obviously looking carefully at the people walking by. The staff at these restaurants have become generally well trained, so we have to be careful that one of the diners doesn't infect them by mistake when they relax their guard, when we relax our guard out there. But I have done a few outdoor dining with family and so on, and I'm still here. So I haven't been tested, but I have a feeling I'm in a risk group. So but so is the president.
So a lot of people have kind of, have expressed worries about it's getting colder, it's getting darker earlier. So outdoor dining is going to be more difficult. Riding a bike outside, you can't ride it in the snow. So, is this going to be a much more depressing winter because you can't get together with many people as much? I mean, if you want to meet your family, you may not feel. Yeah, I mean, I don't think my daughter will meet me inside.
Yeah, and there are a lot of questions about, there are holidays coming up, major holidays, and people often, their families often get together then. At least if you skip Thanksgiving, you may not have those famous arguments that people always have, political arguments over the dinner table, but by then it may well be a settled issue, whichever way, but there'll still be political arguments. But still, obviously, I think there are ways to take precautions and do it safely, but if you are uncomfortable about it, I think the most important thing is, don't go beyond your comfort zone. Remember, you're not only protecting yourself, you're protecting others. And if there are people who are highly vulnerable, getting cancer chemotherapy, for example, things like that, then you might want to be especially careful. And I know it's going to be hard. And indoors, obviously, we all are going to be indoors, and the risk is greater. That's why the flu season tends to peak, when people travel and stay indoors. So I think we have to remember, to be careful and thoughtful. I think it can be done. The Atlantic just published an article on that, which talks about some of it. And I think those people who are interested can look at it and think about, where they think a reasonable set of precautions lies. Some people will want to be completely as safe as possible and err on the side of caution. I would certainly do that if I had any doubt. It's no fun going to a family gathering if you're going to be worried all the time. On the other hand, if people are tested negative, we hope they can get tests, then this can be done safely, taking all the precautions en route. So it requires a lot of thoughtfulness about, obviously, the precautions and how much risk you're exposing yourself and others to.
So pandemics do end. They don't last forever, hopefully. When do you think this will end?
They don't last forever, but I don't know whether they actually really end, in the sense that, the H3N2, the flu pandemic virus of 1968, is still with us. Its progeny are still with us in its seasonal form. So they do end in the sense that enough people are infected or protected, or it essentially runs out of susceptible people. That's why, we're all doing the things we're doing to try to prevent spreading the infection. And when that happens, it has to go from person to person in an unbroken chain. Flu does, this probably does, although it has other places to go, but it will hide out there for a while. So if we break the chain at some points, clearly we can end it, and we could have done that early on if it had been done early on. I was hoping we could. I think there are a number of possible endpoints, one of which is that it will go around for a while. A lot of people will get infected. Maybe we'll get a vaccine, and maybe that will be effective, and we'll have some effective immunity. In the long run, we're all dead, is another Keynes quote. But in the long run, it's quite possible that I may not live to see it myself, but it may become a fifth human coronavirus that causes the common cold, just like the other four, two of which are on the same branch of the family tree. Now, I don't want to be cavalier about that. Complacency is the worst thing. That may be a long way off, but that's probably how those other four got started. But that's going to be quite a while off. So I think, from what we know, it looks like it's going to go around a while until it either can no longer find susceptible individuals to infect long enough that it, essentially peters out after a few weeks. I'm not terribly hopeful that will happen, but if it's possible, or it will go around and perhaps, like the flu, could undergo some changes. We just don't know. That not as mutable as the flu, but still it could adapt itself and come back in the future in slightly altered form. So there are a few end games, but in terms of a pandemic like this, yes, at some point, it'll run out of victims, or run out of fresh meat, if you will.
Okay, well, that on cheery thought, we're going to end it. We're going to say, I want to thank Dr. Morse for spending time with us, and hope you had a good time. And everyone out there, stay safe. Enjoy it's supposed to be 70 degrees tomorrow, so enjoy the outdoors weather while you can. And next week, I'm interviewing Dominique Brossard, who's at the University of Wisconsin, and she's going to talk about strategies to get people to be a little more compliant about mask wearing and social distancing and all the other good stuff that we should be doing anyways, based on the science.
Well, thank you all, and thank you all for your patience with my very long answers, but I hope it gives some context to what is often, a story, often things that appear in isolation. Thank you very much to my gracious hosts. Thank you.
You're welcome. And thank you, Joe Bonner, for doing this. And we're going to be having this on YouTube, and we're going to post it to our YouTube site tomorrow. Okay, take care.
Thank you, and stay well.
You too. Bye-bye.